Hello, listeners, and welcome back to another episode of Tits Up. I am Megan, and as always, I am joined by the lovely and talented Sam. Sam, welcome.
Hello.
Good morning.
Thank you.
Listeners, we are super excited about our episode this week. I know that we say that every week, but I mean that this week. I just said that as if I don't mean it every week. I do. This is just very exciting for me. We are joined today by Heather Rasmus. She is an occupational therapist that works primarily in the realm of oncology recovery. Heather, thank you so much for joining us today.
Thank you. This is new. This is exciting. So I'm really happy to be here.
Wonderful. So, Heather, let's first start with you telling us a little bit about yourself, including your background. What do you do for a living? And I always wonder what the difference between physical therapy and occupational therapy are. And so maybe you can explain that to us. And then also just what makes you tick as a human being. Tell us about yourself.
Awesome. All right. Thank you. So I'm a lymphatic oncology occupational therapist. Kind of a mouthful. But what this means is, so I started out, I have my master's in occupational therapy. And during the year when I studied for my master's, I actually went to South Africa for a little bit. And just for a month there, and I learned about burn therapy. So that's where I kind of fell in love and have a passion also for burn therapy. And wounds and scar management. So that's a little bit of my past. And then I've moved around the country for the last like 8 years. I started out in Pennsylvania, burn therapist, and then I became a hand therapist. So I love talking like upper extremity injuries, nerve injuries, things like that. And then during that time, I also got my certification in lymphedema therapy. So I'm a CLT, are the initials you're kind of looking for a lymphedema therapist. I moved to Seattle. I worked at Harborview. This is the last time I was on the burn unit. A little fun fact is after I left Seattle, my husband and I biked across the country. So that was kind of fun. So I'm into like kind of endurance sports, things like that. I could talk
Lord,
about that.
well done.
Yeah, it was 3 months of biking across the country. So that was a lot of fun. And then we left Seattle and I did a traveling OT and we came to Colorado. So that's where I kind of fell in love with Colorado, eventually moved back here. But before we went to DC. I worked at George Washington University in their lymphatic clinic. COVID hit. I then moved to Minnesota, back to Seattle. And then now we're back here in Colorado. So currently living here in Colorado. And I worked at an oncology clinic here where I became PORI certified oncology rehab therapist. And all that means is I specialize in oncology care as a rehab specialist. And then this year, in June, I left the clinic and I started my own practice. So
Wow.
Shameless plug. Tell us about it.
Yeah, totally. So it's called Empower Lymphatic Therapy. Empower, because I just love to empower women through, getting back to like what they love and empowering them with knowledge, all the things. So that's where it's called Empower. Lymphatic is all about the lymphatic system. So I'm a lymphatic massage therapist. And therapy is because I want to work on strengthening as well. It's not just massage. So I have a home studio here in Littleton, and then I also do mobile service. So around like South Denver, Littleton area. So it's all for oncology therapy.
That's amazing.
So yes, congratulations.
Very exciting.
That's awesome.
Yeah. Thank you. Yeah. I'm learning the business side of things. That's the fun and challenging part. So and then the difference between PT and OT. So PTs a lot of times focus on like movement of the body, like injuries related to that, more lower body. So they'd fit you with like a walker or cane, crutches, things like that. Like that's very PT focused. OTs, so occupational therapists, focus on recovery with like more holistic approach. So learning, like looking at why do you need to get better, activities of daily living, looking at like okay, you need to get in and out of your car, you need to go to work, you need to pick up your kids, like things that are very functional. And if we were going to fit you with something like a PT fits you with a walker or cane, OTs more fit you with like adaptive equipment. So seeing how can you do the activity, and maybe we need to adapt for your body or your strength or whatever the case is to be able to do what you love. So those are kind of the difference between OT PT. When you then look at like an oncology therapist, they can be an OT or a PT. So like in the clinic here in Denver, we had both OT and PT. And our focus is on like recovery post-cancer treatment. So looking at like functional goals, survivorship, how can you also, we can help you tolerate like cancer treatment and when you're going through them. And then the other piece I kind of mentioned on a CLT, a lot of times an oncology therapist will be a CLT, which is a certified lymphedema therapist, because sometimes you can get lymphedema after having cancer treatment. And so there's a lot of cancer therapists that are certified lymphedema therapist. For that, you could be an OT, a PT, or a massage therapist in the United States. It's 135-hour certification. So you just have to go to one of like the Norton school or any of like the lymphedema schools. So it's a certification that you have to get. You don't learn it in school.
I love it. So Sam and I were talking about like, who should we have on to talk about this stuff? Because there is so much more that goes into recovery very often. I'm not going to say all the time, but often there's so much more that goes into recovery after a double mastectomy or a single mastectomy or, reconstruction or whatever, than just resting. And, we'll talk about this a little bit, but I had cording, and I'll have you explain to people what that was. And I needed to go and get special massages and all sorts of stuff for that. But there is a lot more to recovery, I guess, for lack of a better term. I mean, you'll be able to explain it better, but there's a lot more to recovery than just resting, right?
Yes. And even during, you are resting during your treatments, but then there's also things that moving can be helpful. Massaging, all those things can be helpful during it and after. So yes. But you were talking about like physical challenges, physical pain. And that does come along with the breast cancer, treatment and recovery. And this is where like an OT and a PT can be so helpful. I was saying like statistically, and I don't know when this was last updated, but only about 2 to 5% of cancer patients, and this is all cancer patients, actually get to see an OT or a PT, which is such a low number. I mean, you think of like hip replacement, knee replacement, you fall down, you get injured, you go to see a therapist, to get back, and work through strengthening, get back to your daily life. And only at the high end, saying 5% get to see a therapist. It's just too low. So we need to work on changing that. I would say though, cancer therapy has really only been around strongly for like probably the last 15 years. And so it is a newer kind of therapy, I would say, for when we're talking like the big scheme of things. But yeah, only 5% is just so low. We need to work on that. So that's why I'm here.
I'm thrilled that you're here. Why do you think doctors don't? I mean, some do. Like mine told me that I had to go, and I got lucky with that. But why do you think it is that number is so low? Why don't doctors just automatically say, well, this is what you're going to be doing as part of your treatment?
Go get it. Yeah, I think there's a lot. There's a couple reasons. And I think initially one of the things is you're going through cancer treatment and they don't want to add another thing to your plate. And so that's a lot of the times what we hear from doctors is like, well, you're getting blood work. We want you have to go to all these doctors, different, plastic surgeon, you have to radiation. So they don't want to kind of overwhelm their patients with another person to go see. And so that could be one of the barriers. That one's a little like, it can be frustrating because sometimes coming to a therapist can feel so good. It's like kind of one of your favorite treatments or one of your favorite visits. So we're really trying to make that a big change and saying, no, these patients really like coming to therapy. It's not your typical therapy. It's not your like, oh, we're in a gym and we're going to lift weights, it's, we're working with you, we're walking you through, what things are going to be like. It's very one-on-one. So you don't have, it's just not the typical PTOT, I would say, like in a clinic. So that's one reason. I would say, there's probably also limited amount of therapists that are available to go see. So say like your doctor's like, hey, go see someone. And the client's like, I don't, where should I go? And so that can be also a limited, I would say, resource. So we need to get some more people educated on like the therapy side, on being comfortable with working with
I
the
wonder
clients.
if maybe I put a ton of links in the description on this all the time. So I wonder if there
Yeah.
is a list
Yeah.
of, I don't know, really good therapists that people can go to kind of across the
Yes.
country. And maybe maybe we could post
Yeah.
that. I don't know. You might have a better idea of how to find that,
Yeah.
or
So
maybe I could look into that.
yeah, I did. I'll send you a link. There is a national lymphedema network. So it's like lymphaticnetwork.org. I think I posted it to you. They have a whole list of lymphedema therapists, but not everyone has lymphedema. So also just calling your local PT and OT clinic. I always like to, you could research online for your area, but also just calling the clinics and saying, hey, like, I'm going through breast cancer right now. Do you have anyone that can work with me that has like an oncology background? It's definitely becoming more popular. And so I think just calling around and just saying, this is what I'd like to focus on is my, oncology diagnosis, and seeing if they have something available. Calling like the larger
Yeah.
centers, like here in Colorado, like UC Health, starting there and trying to call them. So I think that's a good way to start, and just knowing what to say, saying that you're trying to find like an
Well,
oncology therapist.
let's go into that. That's perfect. I'll put something in the description for that. But so somebody's calling in, let's say,
Hmm.
and they are having certain side
Hmm.
effects.
Yeah.
What are some of the most common
Yeah.
side effects
Let's go
that
through
you
here.
see? Like why are people
Yeah.
coming to
So,
you the most often, or least often, or however you want to talk about it?
mhm. So as a therapist, we're assessing for side effects of cancer treatment, so surgery, radiation, chemotherapy, all of those have side effects. So a list of them would be pain, having physical pain, muscle pain, stiffness, weakness, nerve injuries. Nerve injuries happen through radiation, through surgery, through chemo, actually all three. Um, Lymphedema. So lymphedema, I'll go into that probably in a little bit. That's a whole, piece I'd love to talk about, but not everyone, gets lymphedema. And then scar tissue. So after surgery, having scar tissue. So having someone be able to help you with scar tissue management. And then radiation. There's a lot of side effects from radiation. So I think I'll start with the first one is like
Yeah,
surgical pain. So after surgery, I think you had a mastectomy,
correct.
correct? So there's precautions that you have to follow after of having your surgery, and that's good. We want to follow those precautions from your surgeon. It allows the surgical site to heal. You want that scar tissue. A lot of times we talk about scar tissue being a bad thing, but you want the scar tissue there to heal the wound. However, and a lot of times we're told like keep our arms down, which is also good, important. We want that surgical site to heal. However, we need someone to kind of guide us through getting out of those precautions. So at 2-3 weeks, we start doing range of motion again. So we guide our patients through range of motion. At 2 weeks, that's like the optimal time, optimal healing for your scar tissue. And then at like around 2 to 3 weeks, as long as the wound is healed and you don't have any open areas, we can actually start doing massage at that time. And that could be just like a gentle touching the skin, touching the scar, mobilizing it. So that's something you do want to touch on. And I feel like a lot of times that gets left to no one talks about that. So that's really important. Another thing is muscle tightness. No, you're bound down, you're protecting, you have that forward posture. And I also talk about like, it's a really sensitive area. It's your breasts. I mean, you have your breast here, you have your heart, you have your lungs. They're all in the same area. So of course you're going to protect that area, especially after having a surgery. So we acknowledge that you are going to protect that area. You are going to, like, don't touch me, don't, go near. What happens with that though is you start to get that protective posture where you are, rounded shoulders, and then you also anticipate kind of pain, or you having that anticipatory pain. So you kind of like tighten up. And so just being aware of that, aware of that tightness, being aware of like, how much are you protecting? How forward are you? How stiff are you? And trying to like bring that down and not be so tight in that area. Because those things can lead to muscle pain, shoulder injuries, you name it. So trying to just be aware of your body in that regard. We also, like I said, address the scar tissue. So, going through scar massage, what that looks like, how should that feel, allowing that scar to, you initially want it to dry out. We don't want any wet, scarring, but then you want to, once it has dried out, then you start massaging it with lotion. So we want to have a nice mobile, soft scar. And then, so that's therapies coming in to kind of walk you through all this. Get you back to strengthening, get you back to your range of motion. And we kind of have protocols that we kind of follow through.
I remember after mine, I was going to therapy. I don't recall at this point if it was physical therapy, occupational therapy, but I went to go see someone who was lovely, and she would massage my scars and help me work on range of motion. And I specifically remember those very, very first I keep wanting to say episodes. Those very first appointments. There we go. Jesus. Those very first appointments were really, really painful. Just, and not like she was doing it wrong. It was so raw at that time. Like, yes, everything had closed up, but I had some pretty serious scar tissue that was developing. And she was so wonderful getting that scar tissue to kind of move. But I remember just having somebody touch me there on these, deflated implant, or not implants, the expanders, on these deflated expanders that I had in me, and then everything else that was just trying to heal. It was really painful for about the first one or two appointments. And then after that, I couldn't get there fast enough. It felt so good. It really did. Like, it felt so good. And to have somebody there that understood and didn't expect me to be at a certain point before I should be there. I was holding myself to a really high standard. I should be able to clean and dust and make the bed and hang up clothes and all of this. And none of that was anywhere near happening. And going to see her, yes, it was helping with that. But it started to feel so good just to have somebody touch that area, and I, like you were saying, like that protective posture, I was shaped like a C, I was like, I didn't want anybody to look at me or touch me. I was so nervous about all of it. And when those nerves have just been severed in a mastectomy, and now you've got somebody touching basically where these severed nerves are, it does, I keep wanting to say hurt, but it isn't necessarily hurt. It's just the weirdest stinging feeling, I guess.
Yeah.
And she made that so much better. And I thought it was interesting because, for how amazing my husband was, I talk shit about him on this all the time, and he knows it, everybody. He talks shit about me too. But for all of the amazing things that he was doing with me and for me during that time, he wasn't massaging that area. I think he was scared to touch it or to hurt it. And I think that's why that's so nice to have somebody that knows exactly what they're doing, and they can actually really help you to become more comfortable with that area again.
Yes. And it's something that, like, I have said, like, I will actually sometimes teach partners, husbands, whoever, to touch again, because there's a lot going on, physically, but also mentally after having this major surgery. I mean, for lack of a better term, it's an amputation. It's an amputation of your breast. And amputate. I mean, you guys have talked about this before. This is not a boob job. This is a major surgery, and it's an amputation. And when you have an amputation of a part of your body has to get it's like, what's going on? Like, all your nerves are like on fire because it's like, what did you just do to me? And so learning how to quiet them down, learning how to touch yourself so you can quiet the nerves. And a lot of times, if we are in pain, we don't touch, which is normal, right? But it's actually can be counterintuitive when we're talking about that nerve pain after having like a mastectomy or having your surgery, because you want to touch again, you want to quiet them down. It's like, it's okay, you do the massage to actually kind of address that hypersensitivity that you can get with your nerves. And a lot of times it's not intuitive. And so that's where it's like having that therapist be like, this is okay, this is how you do it. And then also, I actually initially don't, I teach the patient how to do the massage and I do the massage. With the partner though, I actually say, okay, address the muscles. So can I teach you how to massage her back? Because she's so forward. These muscles here, your pecs can get so tight because they're just they're working overtime. And so what happens is these guys get tight, pecs get tight, back gets stretched out forward. You're coming up on the shoulder. These guys get so tight up here. So even I teach the patient, the client, you how to do the massage to touch yourself. And then I have actually the husbands or the partner do like massage to actually quiet those muscles down. I call it my shoulder push, laying flat and just pushing your shoulders back. And the partner will push down. And then it just gives them, it empowers them as well to be like, I want to do something. I want to help, but I don't really know what to do. I don't know how to touch her again. And I'm scared because, you were talking about your drains. You're in a lot of pain, And so getting back to the point where it's like, no, it's okay. And this is what you can do. And I know partners really appreciate that.
I think it's so important to
really
involve the partners too. I mean, some I've talked to and I've read online and all sorts of stuff while I was going through this, all about partners that are maybe not as helpful, I guess, during this whole thing. And I do think that, yeah, it is a little bit scary. And I think a lot of it has to do with the fact that they just don't know. And I can see that almost kind of severing a relationship a little bit, like you sever your nerves and it ends up severing a little bit of the relationship, because when you have this feeling of going through something together with somebody, with your partner, I think that can very much strengthen the relationship. But then if you have a partner that is feeling like they're not involved and they don't know how to help, I think that can kind of sever those ties, and your relationship is difficult anyway enough on the best of days. And then on top of that, you add this where now it's don't touch me, don't look at me, everything hurts, I feel gross, blah, blah, blah. And I think that can do a lot of damage to a relationship, either short term or even potentially long term. So I love that you involve the partners in that. I think that's really, really important.
Yeah, I agree. Yeah. I think going on talking about the nerves though in touching, I think I shared a story with you where I've even had patients like move mirrors up so that they no longer can see their breasts or see the surgical site. And so addressing that as well. You are feeling really vulnerable in that. You're feeling vulnerable with yourself. You're going to feel vulnerable with your partner. But going along the lines of moving the mirrors, your nerves, it's like almost like they have to accept, your new body, your new chest, your new breast, whatever, surgery you decide to do. So that's where it's like trying to get people to touch. It's like accepting your body again. And so that goes, your nerves know it. It's like if you never look and you move all your mirrors, you don't ever look again, your nerves know. They're like, what's going, they're not going to create that connection. And so, yeah, Exactly. Yeah. It's like, touch me again.
That was
So,
me.
yeah.
I couldn't look
So,
in the mirror. I mean, the mirrors that I have in my house, I can't really move them.
yeah.
So I would just like, I was just always draped like I am right now. I'm just like always draped in a blanket.
Yeah. Yeah.
So I would,
Yeah.
I'd hop in the shower and then I'd get out, dry myself off, never looked in the
Mhm.
mirror. I couldn't deal with it. Because at that
Mhm.
point, after surgeries, and we'll kind of go into this, I think this is a good segue into
Mhm.
like chemo and radiation and all of that. But my body
Yeah.
was just so fucked up. Like my tummy was like this pot belly tummy, I think just from all of the meds that I was on.
Mhm.
My face was a perfect circle. For those listening to this, I was just
Yeah.
explaining the exact same thing to Heather and Sam before we started, but that was because of Christmas dinner. Not because of anything surgical, but it was all kind of the same. Like my face was like a perfect circle, my tummy was huge. And then on top of that, I was used to having pretty decent
Mhm.
sized boobs, and now there was almost nothing there, which kind of
Mhm.
accentuates the tummy.
Mhm.
And there was nothing I could do to make myself be like, oh, I love my body. She's trying her best. I
Yeah.
just wanted to light my entire self on fire. Like I was having none of it.
Mhm.
And so I absolutely resonate with that of
Mhm.
where you're just avoiding at all
Mhm.
costs. And I just assumed that I was
Mhm.
going to look and feel like shit for the next few years. And I just had to kind of get used to it. And I just had to accept this new
Yeah.
body that was not at all what I wanted. And that was very difficult. And
Mhm.
maybe that's for later in the episode. Maybe that's for a different episode. But I think it is really, really important. I basically where I was going with this is just saying that my physical therapist or occupational therapist, again, I never remember, but the
Mhm.
therapist that I worked with was really, really helpful. Like
Mhm.
she had me stand in front of the mirror and she was like, first, like, touch the
Mhm.
places that don't hurt, like, touch your arms, touch your legs, touch
Mhm.
your tummy, like, all of that. And I remember just crying through it. I'm like, I hate it. I hate it. I hate it so much. But I think it was a really important part of, yeah, helping you heal, but also helping you kind of accept
Healing.
what is going on here.
Mhm.
And that was tough, but
Mhm.
necessary.
Yeah. Yeah. Well, you probably go through the 5 stages of grief, in
Yep.
this whole process. And so one part of that, yeah, is just learning to accept and touch and see yourself again. So at least once a week, if you're going to see someone, maybe just 1 hour a week, working with your therapist, and that's your 1 hour to be like, okay, I'm gonna do this here, and that's maybe where you start. We all start at different places, and each patient starts comes from a
Yeah.
different background, and so that's where finding a therapist that you really resonate with, that can kind of walk you through that with you, and not rush you. It's a slower process, and just finding someone that you feel like can really listen to you and walk that line with you.
Yeah,
So it's
it is.
important.
Um, so
Yeah.
next kind of topic, and these two I can't really speak to. Sam, you'll be better able to speak to this. And
Mhm.
Heather, obviously, you're the number one person that can speak to any of this. But radiation
From a
and
therapy.
chemo side effects. Like, how does occupational therapy
Mhm.
help with those?
Yeah. Okay, so yes, well, I guess we'll talk about radiation. A lot of times there's a lot of pain, and tightness that comes from radiation. So that's kind of the physical challenges with radiation. So radiation, there's a couple different types of radiation. I would say for this topic, some people have more of a targeted radiation, so it's a quicker, like maybe just 5 sessions. We're just going to go right to where that tumor was, and radiate the area. Or there's also then like more of a all over like your breast radiation. So those are longer time frame. And so I would say for that, when you're talking like multiple weeks of radiation is when a lot of patients can get that pain and that tightness from that radiation. So I would say it doesn't typically start, to be painful initially. A lot of clients are like, "Oh, I'm good. I'm doing good here. Going through it." They may have fatigue, but not necessarily like that physical, pain. But as the treatments continue, is when you start getting the skin actually can get a burn from it
Yeah.
and that tightness. develops. And then there's something that we address called radiation fibrosis. So that can present as like that tightness, muscle pain, nerve pain in the area of where you had the radiation. A lot of patients are like, my skin just doesn't feel right. It just like, I lift my arm or I can't lift my arm. And so that's labeled as a radiation fibrosis. And it can happen up to a year after you had your last treatment of radiation and can last up to 10 years. Or it doesn't go away at all. So it's definitely something you do want to address if you have that kind of radiation fibrosis after having your radiation. And what it really is so you think of radiation, it's a burn in that area. So you're, for lack of a better term, burning in that area, you're radiating the tissue, and then it tries to go through that healing phase, right? So it usually takes 2 weeks to go through swelling and healing of a burned area or radiated area. And then, but you go the next day, right, for radiation. So it's like burn, try and heal, radiate, try and heal, radiate, try and heal. So the skin and your tissues, it's not just skin, but your tissues are trying to heal, but then you keep going back for radiation. So it never gets to go through the healing phases. And so it never properly gets to heal because you just keep going back for that radiation. And so that's what you're dealing with. You're dealing with like a skin that just really never got to heal. And so I kind of think of it as like building blocks. Like if you're building a brick wall, nice and uniform, layers, radiated areas can kind of be like you just threw bricks in a pile and they're like, there's my wall. It's all like mishmashed, right? That those skin fibers never really got to heal and be nice and uniform. And so that's where you feel that. So with radiation fibrosis, it's massage. So we do some massage and also just doing range of motion and stretching in that area.
Do you wait until after all the radiation is done? Or do you do that like during?
Not necessarily. We do see patients during radiation. Now, a lot of times we love to see you before radiation, but also during radiation. If you do have those, you can get wounds and scars and open areas. We don't massage any open area, but you can still go see your therapist who can actually address areas around the radiated area so that you can get some relief there. Another thing is a lot of times we'll see patients who are going to radiation. So say you had surgery, you're in that protective posture, that bound down position. Now they're asking you to lift your arm all the way up so that you could do the radiation. And some patients can't do that. So then that's when they get sent to a therapist because they're like, you need to help my patient so that they can lift their arm up so that they can do the radiation. So that can also be an area you see a therapist for. So it's just walking you through the treatment. But yes, I follow my clients through radiation and after radiation. So some patients don't get those wounds, but if you do, then the therapist should just not address that area and massage around that radiated area.
I remember something similar because I didn't have radiation, but my mom had breast cancer. And I remember her going through radiation. And I remember it looking, I don't know, like just a really, really bad sunburn. Now, granted, I was like I was like a freshman or like in 8th grade, so I don't have a great recollection of it, but I do remember her saying something about like, just having to lift over and over and over and over again, and how that was incredibly painful.
Yeah. And a lot of times your doctor will give you a certain like lotion to use. I always try and prepare my clients to have nice moisturized skin before you go into radiation because it's like a bad sunburn, like you said. So having really like weeks ahead of time, really be moisturizing and addressing your skin there. When you go to radiation, so say your radiation is like Monday morning, you do not put lotion on right before you go into radiation, and your doctor would go through that with you. So you wouldn't want to see a therapist right before your radiation treatment. Wait till, after.
Is there a specific type of lotion you would recommend? We had Emily on the podcast. I think she was episode 7, maybe.
7.
But yeah, Emily was on, and she was explaining when she had a specific type of lotion that she would use before that. And I know that we put that in the
Mhm.
description, and I'm of course blanking on the name of it right
Mhm.
now. But what would you
Mhm.
recommend? Like, are we just using like
Mhm.
Eucerin or like Lubriderm or what?
Yes.
Aquaphor.
Aquaphor?
Yes. So that can be very, so this is where my history of like being on the burn unit really comes in, because we had all different products for that. There's so many different products on the market, and I think sometimes that can be overwhelming. My surgeon that I worked with at Harborview, she always would say, I don't care what lotion you use, I want you to do the massage. That was always the most important thing. She's like, I don't care if you go to Walmart. I don't care if you spend $500 on lotion. Like, doing the massage with the lotion is so important. And so that's always been like how my angle from it, because I'm coming at it from more like a massage scar management side of things. Actually like manipulating the skin, and getting and mobilizing and actually like getting that lotion in there, but doing the massage with it is so important. So I always say on a baseline foundation level, nothing that has any kind of alcohols in it, no scent, no, like get your basic lotion. I love an Aquaphor. That's lovely, but sometimes like an Aquaphor can be too thick when you have the radiation. So sometimes you need something during that time that's not so thick because you don't want to shear the skin during when you're getting radiation. But once that like skin integrity has healed, then you could go to like a thicker lotion. There's so many on the market, and Emily, may have had a great outcome with one of her lotions. Vitamin E, there's like kind of the basics of which lotions to use. From my standpoint, though, is talking about like scar management, touching yourself again. It's really whatever lotion you like. That doesn't have the alcohols, no scent, no Victoria's Secret lotion that you got for
No
Christmas,
bombshell.
nothing like that.
No
Yeah,
bombshell.
what? No, yeah, no, yeah. Keep away from that. That's just going to irritate your skin and dry it out more. So I would say from baseline that, like your CeraVe, your Cetaphil, like I love those. Those are nice. Look at the thickness, see what you can tolerate from the thickness standpoint. But doing the work is what I always say to my patients. Once I teach you how to do like the scar massage and the lymphatic massage or just touching, it's actually like slowly doing the massage, that's I'm so focused on versus what kind of a lotion did
Okay.
you get.
All right. That's helpful.
So yeah,
Do the
yeah,
massage.
do the massage. Yeah, do the lotion because you want to get that lotion in there. You want to moisturize the skin. You want to moisturize the scars, but do mobilize the skin when you do it. So because a lot of people will take a little lotion and like dab, dab, dab. They're like, I'm done. That's good. And that's where I come in. Nope. Got a
I
massage
was
with the
not doing
lotion.
the massage. Like I was going to see my therapist once a week to do this.
Yeah.
But when I would get home, she would send me home, be
Okay.
like, do X, Y, and Z for over like the next week, and I like wasn't doing it.
Mhm.
Just because again, like I got scared
Mhm.
of it and everything hurt, and I was
Yeah.
just like, no, I'm not going to do that. She seems to know what she's doing.
Yeah.
I obviously don't. I'm going to mess it up. Blah blah blah. And I remember getting to
Mhm.
a point where I'm like, I know I should be a lot farther along in like my mobility and pain levels and everything else, and
Mhm.
I'm just not. So that pushed me into a corner where I had to start doing all of the stuff that you've been talking about, and it helps so much. But I don't know if I was being
Yeah.
stubborn or lazy or what it was, but I just did not want to be
Yeah.
doing it. But it makes a big
Yeah. And
difference.
that's
It makes a
where
really big difference.
it does. And that's where we also don't typically follow patients like 3 times a week. Like if you would go to an injury and get like a PT, a lot of times you see a therapist like 2, 3 times a week, for 3 to 4 weeks, and then you're kind of out of there. With an oncology therapist, it depends if you have a lymphedema and if they're trying to do like a total lymphedema treatment. But a lot of times I follow my patients once a week, once every other week. That way I can follow them for insurance, can follow them a longer time, because it is a process. Like I tell, your therapist told you, Meg, like, do this. And you went home and you're like, heck no, I'm not doing this. It's too much. It's just too much right now. And that's okay. Like you have to let yourself like, it's a lot that you're going through. And so that's okay. Like just do it with your therapist. Like I said, 1 hour a week, but over time, then being able to to follow the program and do see the results. That's what I always like to say. Once you see the results, then you're like, oh, now I'll do this because I'm getting the results that I wanted. But that's also where following a therapist, it's not an in and out. You're not coming in and leaving, in 2 weeks and you're good to go. That's just not how it is. And so following someone, think of it as like a longer process so you can kind of walk through it with them.
Okay. You were telling us earlier about like chemotherapy side effects or what was it? Chemotoxicity. Do I have that right? Okay. Talk to me about that. I don't know anything about it.
Yeah. So chemotherapy side effects. So physical challenges with that include like fatigue, nausea, but the chemotoxicity, so cardiomyopathy, and that's when with certain not all chemotherapy drugs have a chemotoxicity or a cardiomyopathy side effect. It's usually like your cisplatin-based drugs, so your platinum-based drugs have been shown to affect your cardiovascular system and put you at higher risk of having a cardiovascular event. And so with that, it's lovely to follow a therapist. We can give you an exercise prescription. It's kind of like we say, like, just like we'd give you exercises to strengthen, we can give you one so you have an idea of following your heart rate. So a lot of times it's making sure that you're not pushing yourself too much, but you're still doing some exercise during your chemo and afterwards. And so what it is we evaluate you. We do like nerve tests, vibration, we do balance tests, and then also get you on a treadmill. It's not like an intense treadmill test, but it's something where we're following your heart rate, your blood pressure, and your oxygen levels. And then we put that into a chart looking at, it kind of gives you an oncology based VO2 max. And then we take that number according to where you're at with your treatment. So it could be before treatment, during, or after. And we put you on a chart. And then we would say, okay, Meg or Sam, like this is when you're exercising, should be your heart rate levels. And so it's very specific again. So you feel like empowered to be like, okay, this is what I should be doing during my exercise. So it's trying to get you like, maybe it's 2 times a week, maybe it's 3 times a week, but it's following the heart rate parameters. So it's really protecting your heart before and after chemotherapy. So that's more like the one side of things. And then the other one is a chemo-induced peripheral neuropathy. So that's when you have damage to your peripheral nerves. And it's different from a straightforward like peripheral neuropathy, like caused by trauma or diabetes, because this is more of a chemo-induced. So we kind of describe it as like, it's almost like a flooding of your nerves, the damage of your nerves from the chemotherapy drugs. And so this is where patients will use like the cold gloves to try and prevent that. There's mixed studies. There's mixed studies in all of this for the chemo-induced peripheral neuropathy on what really works and what can you tolerate, like having cold gloves on your hands through all of your chemo treatments. Sam can maybe attest to. Did you do the chemo?
I did chemo.
No,
I did chemo,
gloves.
but I did not do any icing. I actually had chemotoxicity though. So I had echoes every 3 months for that.
Okay.
And that was not fun. But afterwards, and after I was done with chemo, I had my percentage go back up to a normal rate. So yeah.
Oh,
but
good. Wonderful. Yeah.
Yeah,
so
I did not ice. Sorry.
watching. No. And I think it's such mixed reviews. Some people say, even the studies that we have, like don't have, the evidence is not really there and it's pretty expensive to do. I did read another article about how you can even do compression. So even wearing compression gloves. And one study showed that that was actually similar to icing, doing the icing gloves. And it's less expensive and easier to tolerate. So someone was saying, doing compression. So that would be like getting a compression glove, wearing them during your treatments. Afterwards, like having that, if you do have that neuropathy, that tingling, that numbness in your hands and your feet, a therapist can come in and work with like strengthening and exercise with you. So it's a lot of like intrinsic strengthening. That just means like strengthening within the hands, within the feet. So like clothespins and tendon gliding exercises, grip strength, doing, a ball, but don't do a ball all day. That can lead to other injuries. So working with someone for like intrinsic strengthening. They also show like exercise. So one of the studies was talking about like, should you go see a therapist? But even just doing like general walking after, treatment can be helpful. I was going to say, going through chemo though, being aware of when your body's in nadir, and that's when you're going to feel just so low, like your energy levels are going to be so low, and that usually happens typically, what we say, 2 days after.
It's weird
Um,
because I
yeah.
call it like a chemo high. I'd always tell Megan, like, you never feel bad in the chair. And she's like, what do you mean you don't feel bad in the chair? I'm like, Megan, if you
Yeah.
felt bad in the chair, you wouldn't go back. Nobody would go back. They got to get you all hyped up and high on drugs and pain meds, send you home. And then they tell you to take steroids for a multitude of days afterwards. So it's almost like this weird, like, stimulant high that you're then on, that causes the moon face. And then maybe you have crazy appetite, but it's like steroid induced. And then all of a sudden, 3 days after, you're like, did I just get hit by a semi? Is somebody sticking a shovel in my back? What's going on here? Yep.
Yeah. And they're doing that on purpose. They're trying to get you to that point because it's your body's going to its lowest low. And that's, I guess, the point of the therapy drugs, but being aware of that. So you're not like thinking, hey, I'm going to go for a long walk today, listening to your body. Walking is important. And I mean, we will say that till the cows come home, like walk, but also listen to your body, so being aware when your body is in that low state. Don't go to therapy on that day, so working that through with your therapist and saying, okay, I'm getting chemo on this day, I'm not coming to therapy for the next 3 days. Not an appropriate time, so one other thing on the neuropathy, and I'm not a doctor. I'm not talking, but I will touch base on medication. I am not a doctor, so talk to your medical professional. But a lot of times doctors will hear like nerve pain and they'll give you gabapentin, which is, just a common nerve pain medication. But they've actually shown better results with something called Cymbalta. So just something you could talk to your doctor about. It's actually an antidepressant medication. Still like mixed reviews on it, but it just has shown better results in specifically chemo-induced peripheral neuropathy, not like a diabetic neuropathy, not a trauma neuropathy, but a chemo-induced. So just something to
Two
talk
birds,
with your
one
doctor
stone
about.
on that one, huh? I love
Yep,
that.
that's what I was gonna say. Antidepressant and neuropathy. Sign us up.
I'm on Cymbalta already, and I was like, oh, that's exciting. And then I didn't go through chemo, but also
Yeah.
helpful. If there's ever a time that you're going to
That's
be
true.
on them, probably during cancer treatment.
Yeah.
Heather,
True.
We still have some time, but I want to make sure that we do hit some other items here. And I think that this is like so many of our guests. I feel like this is opening the door almost for so many more episodes that we could do with you and do like deep dives. But
Yeah.
excuse me, will you tell us what courting is and how you help with that.
Talk about lymph. Yeah, that kind of gets us on the road for, I guess, lymphedema,
Exactly.
which we haven't touched base on. Sorry, I just
No,
keep going
I
and
love
going.
it.
Axillary, it's typically axillary cording is what you'll hear of it, and your axilla is your armpit. And so what it is it's a backup on the highway of your lymphatic system. And so the cording is it's backed up on your highway. And so what it feels like is like you can't raise your arm up. You feel restricted. You feel like, I kind of describe it as like a violin string. Like that's kind of what it can feel like. So if you feel that in your armpit, that's typically like the thickness of it. And it really feels like there's like a cord, something like a rope holding you down. And so what you do with that is massage, and work on teaching you how to do lymphatic massage, and then also doing stretches and shoulder range of motion. If you feel that cording, don't like let it go and say, oh yeah, oh gosh, something's holding me back, I should just keep it down. Again, do the opposite of, you can work with a therapist, but getting those range of motion going with your, so that it doesn't keep going to pull you down. So you want to get some range of motion. I never have my patients go to pain. Yes, it can be uncomfortable, but it's more of a stretch. It's like, I actually play the game. Maybe it's because I have kids, but red light, green light, yellow light. And so with any kind of my treatment, we don't go to red. We don't go to pain. We go to yellow, right? We're in green. We go to yellow. When we get to red, we kind of come back to the yellow, because I never, one, want to induce pain. Pain, I feel like then you go into protection, right? So with all this treatment, yes, it can be uncomfortable, but not painful. And so I think that's also a nice introduction to saying, okay, like listening to your body when you're doing this touching and massaging. We're not encouraging in a painful state. You'll get there, just keep going. Like maybe that first day you can lift up just to your shoulder height, sure, and then do some massage, right? Maybe like in a week you can get like 10 degrees more. That's okay. We don't ever like push, grind, get you there right away. So it is a
Yeah,
process. But yeah, the goal is to
I
smoothen that
had
cord.
cording and I didn't know what it was. I just thought everything was tight, and I had
Yeah,
my little T-Rex arms going
totally.
for a long time. So when I finally started to like,
Mm-hmm.
I don't know if you can even tell, but like when I finally could like start kind of doing this, there was like, it basically went
Mm-hmm.
from my wrist, I think I remember, into like, yeah, pretty much all the way into my armpit. And I couldn't really stretch all that much, so I wasn't doing it. And I mentioned it offhandedly to my therapist, and I was like, this is it's really tight, but I don't really know. All right, everybody, we are back. We had a little bit of a technical difficulty. Bear with us. This is not our primary job. We're figuring it out. Anyway, so we were just talking about cording, and I want to be able to touch on, before we're done for today, I want to be able to touch on lymphedema. That's where I get the feeling your passion is. And I want you to explain to people, what is lymphedema? What do you do about it? How does it affect your life?
Mm-hmm.
And how does occupational therapy help with that?
Perfect. Yes. So when you talk about lymphedema is the condition where you have swelling of your tissue. And you'll notice that as your, arm or wherever it's affecting you gets larger, and it's a chronic swelling. So when you talk about lymphedema, like I said, it's the condition, it's to do with the lymphatic system. So the lymphatic is the system in your body that cleans your fluid. So what's good to know, we all kind of know when we get sick, our lymph nodes get a little swollen in our neck. And a lot of times we just think, oh, we have a couple lymph nodes in our neck. We actually have 400 to 800 lymph nodes in our body that are working in our lymphatic system, right? And so their job, is to filter our fluid. So it's our interstitial fluid. So it's not your blood system. That's part of like your cardiovascular system, your lymphatic fluid. So it cleans about 3 liters a day, and then gets it back, into circulation. And so when we talk the lymphatic system, you have them in your head and neck region, you have them bundled in your axilla or your armpit region, and then in your groin area. What's important to know, I would say, is that they are separated into what's called, into like, I kind of say like into neighborhoods. So these collectors all go to this, these lymph nodes, these collectors go to this side, your head and neck stays, you're in that quadrant, and then both your legs. And so what happens with lymphedema is that either it's somehow the lymphatic system has been damaged, so it's not working as efficiently. And so either you're born with that, where it's called a primary lymphedema, so you'll see babies that have swelling, that's a primary lymphedema, their lymph nodes are not working properly, or a secondary lymphedema, and that's usually what comes in with breast cancer. So if you say you had breast cancer on your right side, the damage to the lymphatic system would be removing some lymph nodes, right? Makes it less efficient to process your fluid. Or radiation can also damage the lymph nodes and the lymphatic system, makes it less efficient. You still have a working system, it's just not as efficient. So some people say, oh, it's like totally damaged. It's still working, it's just less efficient. And so that's where you'll notice a slow swelling. I kind of say it like it's as if you had a bathtub and your drain went from, 5 inches wide to like 3 inches, right? We still have a drain that's draining fluid, but what's going to happen to the water that keeps coming in the bathtub? It's going to build up because you have a smaller drain now. And so that's where you go and work with a lymphedema therapist, work on getting that swelling out. You want to catch it early, if you can. Again, working with a lymphedema therapist, and I can kind of go into that ways. There's machines that we do that we test fluid so that we can catch it early. Yeah, I think of it as sometimes, there's so much I could go into. I don't know how much time.
Sorry, I was going to ask, is that when you see people wearing like compression sleeves? Does
Yes.
that help?
And if you notice, if they only have cancer on the one side, you'll only see it on that one side. And that's why I was saying the watersheds, you will only get swelling on the area, the quadrant, that neighborhood that was damaged. So if you have right breast cancer, you are not going to get swelling in your left arm. It doesn't work like that. It stays in its quadrant. So whichever area was damaged, that's where you would notice the symptoms and the swelling or the achiness. It usually starts with like an achy arm or, uncomfortable. And then, because it's a very slow process. The sleeve that you see is a compression garment. And that's one of our tools in our toolbox that we use to address swelling. It's not the only one. Some people get nervous. They're like, I don't want to wear that the rest of my life. It doesn't have to be. So we kind of work with you, but it's one of the tools in our toolbox is you wear a compression. You're increasing atmospheric pressure when you're wearing a sleeve to not allow that swelling to accumulate so much into the arm or wherever you're wearing the compression.
What are some of the other tools, I guess, in the toolbox for that?
Yeah. So one of the tools is massage. So lymphatic massage. What you're doing, so the lymph fluid, how it moves is when you move. So you have a heart that pumps blood, right? There's no pump per se in the lymphatic system. It's you moving. So your muscles moving and you walking, that's moving your fluid. So, so another tool would be one, exercise. The lymphatic massage, what it does is you're manually pushing fluid out of the area that you don't want it to be. And so that's where manual lymphatic drainage comes in. You'll hear it as MLD. And so there's different channels within your body that you can push that fluid. Your therapist can complete that on you and then also teach you how to do general manual lymphatic drainage. The other thing is keeping your skin intact. So when you have a system, right, your lymphatic system cleans your fluid. If you now have a system that's not efficiently working as well, you want to make sure that you're not getting any extra bacteria in that quadrant because that puts extra stress on the lymphatic system to work harder to try and clean that fluid, correct? So what you do is that's where also like moisturizing comes in. You want to moisturize that quadrant that got affected during breast cancer. And why you do that is open skin, right? When you have cracked, dry skin, that's open areas for bacteria get in. Bacteria gets in here, you're at risk for what's called cellulitis, or an infection, a serious infection. And so if you do develop lymphedema, you are at a higher risk of getting cellulitis because your washing machines or your lymph nodes are up here. You have bacteria down here. It's not efficiently cleaning it. Well, now you're at higher risk of getting like a cellulitis infection. So skincare is important.
Dang it. So does that mostly come from mastectomies? By like kind of severing those, or does it come also from like radiation and chemo?
Yes to all three, I guess.
Okay.
we don't and we don't know why some people get it and others don't. You can have two people very similar and one person will develop it and another person won't. But anytime you do surgery, you are cutting those lymph collectors, those little collectors that are in your lymphatic. They can regenerate. So, it's not like everyone who gets surgery doesn't get lymphedema, correct? So
Right.
it does, but that's one area where you can put extra stress on the lymphatic system after surgery. It's really, when a lot of people get, if it's gone to your lymphatic system and you had to get multiple lymph nodes removed, then you're at a higher risk of having lymphedema. Also radiation in that area, multiple rounds of radiation can damage those lymph nodes and put you at risk for lymphedema. I would say I see it a lot less. We tend to catch it earlier. I mean, back when I first started 15 years ago, that's a long, I would have patients that they would only come to me when they had lymphedema and their arm would be like 20% bigger than the other side. Nowadays, I don't feel like that happens as often, that a doctor would wait that long to get you in to see a therapist. But signs and symptoms are heaviness in that arm, achiness. You're going to, go to the grocery store and you're just like kind of like shaking that arm around, like, oh man, that feels really weird. That's a sign, hey, go get to see someone. We can do something. There's not only like circumferential measurements, meaning taking a tape measure and measuring to compare right to left, but it's an LDEX score, or what's called a SOZO machine. And so you send like an electrode through both your arms, and then it measures the resistance of that electrode going through. And the higher the resistance, the more swelling you have. So it gives you a number on your resistance. If you have a higher number, then you're at risk for lymphedema. We get you in a garment and try and prevent it from even happening in the first place.
I can't wait for us to do a whole episode on this. Like that's no, truly. I mean, I know that like we're just kind of touching on things today, and I mean, the major point that I'm getting from all of this is like go see a therapist soon. I mean, when you and I were talking just a few days ago, you were saying that you would like to have people come and see you even before surgery,
Mm-hmm.
before chemo, before radiation, before any of this shit happens.
Mm-hmm.
Come and see you because you can do some preemptive work with people to make it not as gnarly, right?
Totally.
It's my medical term, just not as gnarly.
If you could see a therapist prehab, we call it prehab now instead of rehab, go see someone before, get a whole education on this. So if these things happen, right away, oh, she was talking cording, that's cording. I need to go get in there. Or, man, I'm really feeling this. Or, there's so many things that we could talk about ahead of time so that you're prepared. And then we also can see you ahead of time. Oh, we've actually put people on the SOZO machine and been like, you actually already have some issues with swelling before you even started breast cancer treatment. And then they say, oh, wow, and so it's something that we've already caught early. We're already treating it before, because you can imagine if they've already have some swelling issues now going into any kind of treatment, it's like it's going to happen, so trying to catch that early is wonderful. So ideally seeing someone before you start any of your treatments. If not, trying to get in 3 weeks post surgery to have a check-in and see how you're doing, get you back to moving. That would be ideal, is like that 3 week point after surgery.
Wonderful. Thank you so much, Heather. Sorry we had technical difficulties, and for all of our listeners, I hope this ends up sort of coming out okay. But this was so much information. It was really, really good information. It's a lot of stuff that people don't talk about.
Mhm.
A, because they don't know,
Mhm.
and B, because when it does happen to them, it is seen, I think, as kind of this auxiliary type of treatment.
Mhm.
But to me, it was one of the number one things that helped me get back to sort of feeling like myself and having that range of motion and
Mhm.
finding some level of acceptance with my body at the time. Like it was so, so, so important.
Mhm.
Um, so let's, before we kind of close out, I want you to one more time, shameless plug. So where can people find you? Website, social media, email,
Mhm.
any of that, whatever you want to give out.
Yeah, thank you. So my website is the name of my business. So it's empowerlymphatictherapy.com. And then my social, I'm just on Instagram right now. So empower your lymph. So lymph or lymphatic is, Lymphatic. I feel like people don't always get that correct. So social media would be empower your lymph. And then my email is empowerlymph@gmail. So any way to reach out would be wonderful. I'll get back to you.
Wonderful. Thank you so much, Heather. And I cannot wait to have you on future episodes. This is wonderful. Very, very thought provoking. I mean, a lot of this I had kind of just put out of my head. And now I'm thinking about it again. And I think it's going to be very helpful for our listeners who are going through this now
Mhm.
to have that little light bulb moment and say, oh, this might be something I need to go see somebody about. Maybe this isn't just the usual run of the mill, I just had a double mastectomy or I'm going through chemo type of thing.
Mhm.
It can make your life a lot better,
Yeah.
listeners. Make your life a lot better. So everybody, thank you again for listening to this week's episode of Tits Up. That is our show.